Dear colleagues, dear friends, thanks again to the possibility to present this data to the Bulgarian students in Sofia, but not only. It's about a metastatic nodular melanoma developing on NEVUS SPILUS during intake of beta blockers like BISOPROLOL, NEBIVOLOL, and ACE inhibitors PERINDOPRIL, links to drug-related Nitroso Carcinogenesis and Nitroso Carcinogenesis. There is no conflict of interest, no financial support for this study. As stated before in our previous presentations, polycontamination within the multi-medication in polymorbid patients could be seen as one of the most serious obstacles at the moment for the current concept of the skin cancer's pathogenesis in relation to the so-called metabolic reprogramming of the cancer cell. Recent clinical observations give strong indications that the number of potentially contaminated drugs taken by patients could be seen as a determinant of the severity of the clinical picture and hence of the prognosis of patients with skin cancer and melanoma in particular. So that the concepts of the drug-mediated nitrosogenesis and oncopharmacogenesis of skin cancer, for example, find their logical explanation precisely in the context of this contamination, which has been associated for decades with the generation of heterogeneous forms of cancer, but is a consequence of dietary intake of nitrosamines, for example, stomach cancer, colon cancer, and so on. It is the reason that we have, exactly for this reason, we have initiated analysis, retrospective and prospective in nature, of data in patients with cutaneous melanomas, but not only, to establish or rule out an association between the intake of certain drugs catalogued in the FDA list as a potentially contaminated with carcinogenous nitrosamines and the subsequent or parallel development of skin cancer. In the case presented, melanoma developing on NEVUS SPILUS during the intake of beta blockers and ACE inhibitors, for example, was shown and explained. All the drugs taken by the patients were currently listed in the FDA list from 2019-2025, and the intake of bisoprolol, nebivolol, and perindopril is practically could be not only seen as an intake of a pure generic substance, but like it could probably act as carcinogens cocktail of three different carcinogens or nitrosamines within these drugs, which might be seen as responsible to some part for the melanoma development and progression. We report a 51-year-old female patient with congenital pigmentary malformation, localized laterally thoracic on the right, which has changed significantly in shape and color over the past year. The change of this lesion in practice proved to be a reason the patient's visit to the outpatient dermatology and dermatologic surgery clinic. The age of the so-called mole is about 10 years of age, and the data of this occasion are not entirely certain or definite. The patient informs of 2 available pregnancies to date at 38 and 44 years, within which the intensity of pigmentation changes slightly and progressively became more intense, but the size of the lesion does not change overall during this time. There is also an evidence regarding the anamnesis of these patients about 2 to 3 painful sunburns in the 30 years ago. However, this did not affect the area of the pigmentation that was covered by the patient's swimsuit or bra, according to the history, and to the current location of this lesion. One of the burns was adjacent to the pigmentation and was associated with formation of a bulle, but was not affecting the lesion. The patient had seen a dermatologist 10 years previously regarding the pigmentation, and no definitive assessment of the lesion's dignity was made during this examination, but her follow-up and eventual surgical removal was recommended. What sporadic mechanical irritation of the lesion was also present on several occasions over the years, but was not accompanied by bleeding. The lesion has changed in shape, size, and intensity in recent months, about 4 months, with the area also becoming slightly sensitive to touch. During the dermatological examination, a brown patch of melanization dotted by smaller dark black macules measuring 10 by 15 cm was found. In one part of the lesion, there was a nodular tumor formation with diameter of 2 by 1.8 cm, asymmetrical location, relatively clear demarcation from healthy tissue, heterogeneous color, central nodular brownish gray area, projecting in the periphery at 11 to 17 o'clock, surrounded in the rest by intense black pigmentation, significant elevation of the lesion on palpation in the central area, and dermatoscopically absence of a melanocytic network, heterogeneous coloration, gray-pink regression zones. And on the basis of this clinical pathological morphology and dermoscopy, the working diagnosis was nodular melanoma developing within the NEVUS SPILUS lesion. Here you see exactly the lesion, and it is an enigmatic lesion because it is very, very rare to see melanomas developing on NEVUS SPILUS. However, there were several factors which might have contributed to the development of this melanocytic lesion of nodular melanoma. One of them is sunburns, pregnancy, mechanic irritation, and drug intake, of course. From that point, is a concomitant disease by the patient. The patient has had a spoken arterial hypertension with about 10 to 15 years. Medication intake on this occasion was irregular, and the patient's systemic medication for the past years includes BISOPROLOL 5 mg, PERINDOPRIL 10 mg for 3-4 months to date. 11 years ago, he first started with the intake of BISOPROLOL once daily for about 3 years, also taken during her pregnancy, followed by NEBIVOLOL once daily for 2 years after delivery, after which this intake was discontinued. And so, preoperative screening and staging was performed, CT contrast revealing dissemination of the process into the lungs, and the lesions were determined to be metastatic 1. Evidence on focal lesions in the lung parenchyma and with secondary features were available. Medially in the left lung in area of the 8th segment, a circular lesion of 22 mm is seen. And periphery in the right lung, several nodular lesions, also measuring to 3 mm were seen in the upper and the middle lung fields. In the mediastinum, single lymph nodes measuring up to 5 mm are visualized paratracheally, but they were not pathognomonic. So, what is going with this patient? The lesion, which was suspicious for nodular melanoma, was surgically removed with a surgical margin of no more than 1 centimeter. Proven this, we have in this patient already proven operatively distant metastasis, and it has shown that it is intermediate thickness melanoma with breast wall thickness of 2.28 millimeters, stage 4, because we have a distant metastasis to lung, and the BRAF test was negative. The patient was referred to the regional onco center for dermatology for follow-up and pembrolizumab infusions. Here you see the lesion, which has been very, very nice in the images, with the surgical margin, removal into the depth in the muscle. Then we have closed it, and the patient was referred straight to the cancer center. After 6 months monotherapy with pembrolizumab, a complete resolution of the metastatic nodule was observed, and the patient is now disease-free. So why we again want to mention this? It is very, very interesting that the beta blockers and alpha inhibitors are principally associated with the generation of photosensitivity and phototoxicity, according to the literature data worldwide. These literature data so far do not answer the question, what exactly induces this photosensitivity, toxicity, and consequently carcinogenicity? Photosensitivity is associated with phototoxicity and activation of the so-called photocarcinogenesis of skin cancer, for example. It is known for decades. UV radiation and cancer, photosensitivity, phototoxicity, photocarcinogenicity. However, it is also interesting that some of the nitrosamines in drugs are photocarcinogens and genotoxic substances simultaneously, which are able to exert their action even before they are metabolized in the liver. So that what is even more interesting is that these nitrosamines are also contained in the many and most of the drugs, but not officially. It is these properties that could be linked in concepts such as PHOTO-NITROSO carcinogenesis, and there are currently no data on the phototoxicity of the important nitrosamines or nitroso derivatives at present, NDMA, NDMA, NMBA, and many others. Of course, ACE inhibitors and melanoma is already, this link is known. 4 important international papers shed some light about this topic. I'm starting with paper from Connor and colleagues, antihypertensive medications and risk of melanoma and keratinocyte carcinoma, systematic review, then photosensitizing antihypertensives, 2024, then ACE inhibitors and stimulates melanoma cell invasiveness, 2022, and once again with 2017 the enigmatic paper for Betrismadron. What we have overlooked are antihypertensive medications and risk of melanoma and keratinocyte carcinomas. A systematic meta-analysis, the newest one in 2024. Some antihypertensive medications are photosensitizing. We have spoken about that. The implication for skin cancer risk remain unclear because results from prior studies are inconsistent, and as new evidence is published, we have a new vision for skin cancer's pathogenesis. Increased risk were seen for melanoma and ACE inhibitors, about 10%. The quality of evidence was low, but it is presented. So, it is an evidence that ACE inhibitors and melanoma development is a link, is an existing one. The problem and the weak points is again that the lack of comprehensive assessment of data on additional factors in the context of concurrent simultaneous drug intake and relevant polycontamination have the patients with polymedication and eventually polycontamination being excluded from this study, or is this study including all patients taking only ACE inhibitors? Lack of assessment of a mutational pattern in described works, whether there is an overlap of the mutational pattern generated by photocarcinogenesis with this form nitrosamines. Is this actually the same one? And I believe it is the same one. Lack of information in each paper where there were not contaminants in the form of nitrosamines are actually present. Second paper, observational study, German journal, photosensitizing antihypertensive medications and risk of skin cancer among postmenopausal women. Here we speak again. Here we have the 2024, 1 year ago, ACE inhibitors and are associated this time here with non-melanoma skin cancer, but antihypertensives and diuretics and angiotensin receptor blockers were each associated with elevated melanoma risk. And these differences in the different papers could be explained due to the different concentration of nitroso contamination in the different drugs. Use of these antihypertensives overall and several individual classes thereof were associated with higher incidence of non-melanoma and melanoma with dose-response relationship. When you take more contaminated drugs, you have more cancer. So, it is a serious risk, as mentioned, for sartans and melanoma and diuretics and melanoma, but for ACE inhibitors is more evidence in this study for keratinocytic cancer, for example. There are some more experimental works speaking or focusing the attention about the lisinopril, that in some cases it would stimulate the melanoma migration invasion, so that some of these data are indicative that when we have already melanoma cells, some of the drugs might trigger the metastasizing. It's also interesting thesis. The vision of cancer is changing, and the roles of nitrosogenesis and oncopharmacogenesis are on the way to be clarified and new, redefined or established. The active substance of these ACE inhibitors is probably also able, under certain conditions, to potentiate this aggressive behavior of the already existing melanoma cells. And of course, I not forget our friend Beatrice Nardon from Italy, but now in USA, as inhibitors, 142% and 71% adjusted and not adjusted risk for developing melanoma. This is not our study; it is American study. It is of the journal in the Journal of American Academy of Dermatology, which is indicative for the connection between drug intake and melanoma development. Same could be said for IRBs and thiazides if you check the table, and this is a very, very interesting observation. We want to speak, of course, about the metabolic reprogramming shortly, because the metabolic reprogramming is the hallmark of cancer as a whole, and the link between the activation of RAF oncogenes and tumor suppressor inactivation, like the guardian of genome, are the most serious obstacles for the cancer generation or initiation phases in general. The most important environmental factors is the UV light, UVA, UVB, and tobacco-specific nitrosamines. And the most reasonable question is nowadays, should the concept of this metabolic reprogramming of a tumor cell, of skin for instance, differ only due to the fact that carcinogens enter the body via controlled permanent continuous drug intake, rather than via cigarette smoke or sporadic intake? And we are referring to a serious number of carcinogens and NDSRIs not yet fully studied. Some of them seem to be genotoxic and at the same time are phototoxic. And the tests of the regulators are not calculating the additional phototoxic risk and from here developing photocarcinogenicity. And that's why we have a skin cancer after drug intake in probably acceptable daily intake doses, as well as also found as component of a standard medication like nitrosomorpholin, for example. Concurrent intakes of drugs of heterogeneous classes declared as hypothetically contaminated with carcinogens, according to the FDA list from 2023, could probably hardly be limited even within the limits recommended by regulators. It is the contamination of polymedication taken by patients within polymorbidity that appears to be the most likely probable cause of cancer in general, or it's a substantial cofactor at least. The thesis presented so far that polymorbidity is the cause of cancer is gradually but more than surely losing its supporters. Nitrosogenesis of skin cancer is a modern concept in the medical literature that links the intake of nitrosamine-contaminated drugs and the subsequent development of heterogeneous forms of skin cancer and melanoma especially. The polycontamination of currently about more than 300 of the most globally distributed drugs with nitrosamines has been since 2023 officially declared in the FDA recommendations to the manufacturers, and the number of the effective preparations is growing every day. The problematic issue at the moment is the balance between the officially disclosed from the pharmaceutical companies and the hidden not disclosed from the FDA and EMA to patients of clinicians' contamination data about the preparations. It is noteworthy that the concomitant or consequent intake of drugs with potential carcinogenic potency of 4 and 5 for a relatively short period could be associated with the development and progression of cutaneous melanoma based on NEVUS SPILUS, for example. It is a hypothesis. However, we have not to forget that tests of FDA, AIMS tests and CPCA tests in rodents, in the AIMS tests in bacteria, they present they are static tests and they do not calculate the photocarcinogenicity. And the photocarcinogenicity is additionally a side effect of these nitrosamines to their genotoxic and mutagenic potential. There are 4 and 5 carcinogenic potency, metabolic reprogramming, nitrosamine, skin cancer. This is a topic for life. And this is more than a real craziness, I can say. 2 very interesting facts could not be ignored anyway. Certain nitrosamines within the monocontaminations, like NDMA, for example, could have a direct activating action towards certain oncogenes, such as RAS oncogenes, for example, and at the same time, once metabolized in the liver, they could be also mutagenic, like methyldiazonium. That is the reason that shows us, or this is the reality, that the monocontamination with a single nitrosamine could have a polycarcinogenic effects given its metabolized and unmetabolized form. And this is a statement not by us, this is our interpretation, but this is a statement by Michael White in the JAMA network. It's a very serious journal, and this is probably the tip of the iceberg. We have to go further to find a real reason for all this. Several new important international papers shed light on the possible links between oncopharmacogenesis, drug-related PHOTO-NITROSOgenesis, carcinogenesis, and the skin cancer development and progression. And as we know, some nitrosamine seems to be photocarcinogens. This is well known since 50 years. Some nitrosamine seems to be mutagenic carcinogenic. This is also very well known. These are the tobacco-specific nitrosamines. Here we have to answer the question, are the tobacco-specific nitrosamines and the contaminants in drugs, are they one and the same, or which are the differences between them? Some medications contain photocarcinogens and nitrosocarcinogens, such as nitrosomorpholin and monosodamine, for example. And we know that the metabolic reprogramming by tobacco-specific nitrosamines includes first the UVB light, and second the tobacco-specific nitrosamines as one of the most serious obstacles for the development of cancer. And exactly in the critical review of toxicology is mentioned that these tobacco-specific nitrosamines are attacking critical target genes, including the RAS oncogene p53 in the human genome, and the genotoxicity of one of the nitrosamines found in drugs is additionally has been registered as phototoxic after UVA radiation and before its metabolization in the liver. This is another proof that we have phototoxicity and genotoxicity. And the phototoxicity is additional problem to genotoxicity. This is not recognizable by the Ames test, for me especially, and by the CPCA test. Nitrosomorpholin is nitrosamine, it's a photocarcinogen, genotoxic substance without metabolic activation, mutagenic, could be also seen as potential environmental genotoxic factor when found onto human body, but also probably when taken via drugs. The crisis with the nitrosamines, the main questions is not has the crisis been overcome and how to overcome it. And it is more than sure that we can overcome it with elimination regimes. This paper is also a new paper, relatively new, 2023, in the well-known pharmaceutical journal with a well-known collective also. They are postulating the following one. You can see it here that one of the most serious contaminations with nitrosamines are affecting the antihypertensive, antidiabetics, and the antiacids. These are losartan, valsartan, metformin, and ranitidine. And the problem is that this contamination could be a severe one. Polycontamination of this single drug with two nitrosamines is now a reality and not a myth. And the contamination of drugs with nitrosamines, which are already proven as photocarcinogens like nitrosomorpholin, is also a reality. It's not a myth. These nitrosamines have their mutagenic but also carcinogenic action before, after metabolization, and after that, so that we have to deal with big carcinogens. There is no single medication preparation or medical preparation on the market at the moment where we can be 100% sure that it has been not affected due to the nitroso contamination. Nitrosamines and elimination regimes must to stay a priority. And clinical pathological correlation seems to be from paramount importance, and the clinical observations are the most serious possibility to serve for a better for humanity and for the world health system. The polycontamination of the polymedication appears problematic with respect to the future development of heterogeneous cancer, inclusive cutaneous melanoma. The monitoring of these possibly interrelated events could be seen as at least indicative of the key role of the drug-related nitrosogenesis in skin cancer generation, and we present some of our data in this regard. Two papers of our team are indicative that the simultaneous intake of ACE inhibitors and beta blockers in the context of possible polycontamination with nitrosamines could trigger the development and progression of keratinocyte cancer and melanoma precursor lesions in dysplastic nevi. Here we post some of this data. Beta blockers and ACE inhibitors might be responsible for this development and progression. Another study is showing that the combined intake, this is another case observations where ACE inhibitors and beta blockers could be linked to the rising skin cancer incidence in some geographic regions. And two additional papers of our team are indicative that the intake of only ACE inhibitors in the context of this contamination could also trigger the development and progression of cutaneous melanoma or dysplastic nevi. Of course, accordingly, common link is here the nitroso phototoxicity. It is an enigmatic paper regarding the flavor of that. Perindopril induced thick melanoma and BC at the back, potential of the genetic substance or and possible nitrosamine contamination as skin cancer K-triggering factors. So, our study recently presented data seems to be indicative that the possible contamination of bisoprolol, NEBIVOLOL, and perindopril with nitrosamines could bear the risk for at least to play as cofactor for the simultaneous development of cutaneous melanoma, for melanoma development, or dysplastic nevi, for example. Nitrosogenesis and oncopharmacogenesis of skin cancer seems to be a reality and not a myth. Short-term intake of these drugs is associated or could be associated with a relative short-term risk of developing of cutaneous melanoma, as in the case presented by us. For the dermatological science, however, some important dilemmas remain regarding nitrosamines and their pathogenetic relevance. Does certain additional old new nitrosamines or its metabolites have a triggering point to absorb photons and trigger phototoxicity and carcinogenicity? The answer is yes, for sure. Does it or its metabolites have the potential for systemic bioavailability to accumulate in skin to trigger skin cancer? The answer to these questions are somewhat and more than clear, but they are delays detrimental to the objective truth concerning the fate of billions of patients. And PHOTO-NITROSO of skin cancer remains no more a hidden truth and at the same time controllable process. Drug-related nitrosogenesis is essential part of the oncopharmacogenesis of skin cancer's pathogenesis, and polycontaminated drug intake could be and is very often associated with the development and progression of the cutaneous melanoma. Early dermatologic surgery is a reasonable and adequate solution for a newly arising drug-induced tumor, but it has no preventive effect. Paraphrasing the availability of nitrosamine to flow carcinogenic potency within the polymedication contaminated drug regimen does not ensure patients against the relative short-term occurrence of skin cancer melanomas, development and progression based on phototoxicity related indirect effects. The assays proposed by the regulators to determine the carcinogenic potency of nitrosamines are insufficient in terms of their future predictive value concerning the development of skin cancer and melanomas in particular. The reason for this insufficiency lies in the fact that carcinogenesis is a dynamic multifactorial process in the context of the so-called metabolic reprogramming of the tumor or cancer cell, and the tests are static and non-indicative. Also, the photocarcinogenic effects seems to stay uncalculated. Currently, only complete elimination regimes or regimens for carcinogens in drugs seems to be the best insurance for the end consumers. Dunning-Kruger effect on the academic silence of the lamps. Is it time to break it? Time to overcome it? The Dunning-Kruger effect is a cognitive bias in which people with limited competence in a particular domain overestimate their abilities. It was first described by Justin Kruger and David Dunning in 1999, and some researchers also include the opposite effect for high performance, their tendency to underestimate their skills. In popular culture, the Dunning-Kruger effect is often misunderstood as a claim about general overconfidence of people with low intelligence instead of specific overconfidence of people unskilled at a particular task. The dilemmas to clinicians and consumers and regulators and manufacturers remain open. Is it competent to take drugs that contain carcinogens and nitrosamines? Is it competent for this issue to continue for decades with impunity? Is it competent for regulators not to inform consumers about the presence of carcinogens, genome modifiers in medicines for decades? Is it competent for certain geographical regions to be affected by nitrosamine contaminations and not others? Is it competent not to reflect this in regional and global health bulletins on side effects? Is it competent to have the concentration of carcinogens within the polymedication exceeding many times the daily allowable doses of carcinogens and have no solution for this? And is it competent when the intake of nitrosamines in medicines is associated with the generations of melanomas and heterogeneous cancers to have no alternative to this, or when one is available to conceal it skillfully? Is it competent to determine carcinogenic activity in humans based on mutagenic tests for bacteria and rodents? And is it competent to be poly-incompetent within a framework of mass incompetence? We have published this paper in a very nice PubMed indexed journal, and we stay proud and happy of it. I want to say thank you for your attention. Many greetings from the Bulgarian Society for Dermatologic Surgery from Sofia.